Can you hear me okay? I'll take that as yes. So hello, welcome to the final revision lecture for this year. And unsurprisingly, this will be a review of semester 2 pharmacology. So let's get started. Work with me. Okay, quick introduction. If you think some of these slides may seem familiar, you're probably right. They've been adapted and updated from previous PS Papa lectures. I've summarized some parts and added more details on others. Feel free to ask in the chat, email me, or if I don't get around to answering your questions, use the link in blue and someone from our PS Papa team will answer. Sources, as you can see, are not mine. And a disclaimer, none of the images used are mine either. So just a quick summary from our last year's exam. This is our exam breakdown. And so the two final papers from semester 2 each had 12 pharmacology related questions. So I guess worth knowing, but also not a super big part of the exam. So quick overview, we'll be focusing more on the later topics, but still skim over the earlier ones just to cover all of semester, because why not? Okay, first up, pharmacokinetics. Easy one to start off with. I have questions throughout, so I really encourage you to participate and learn actively. And it also tells me which questions I should be explaining in more detail. You can also PM me answers. That'd probably be better actually, so that everyone gets a chance to think about it. So yeah. Yep, keep them coming through. Okay, so this was an easy one. So there are 5 phases and it's pretty self-explanatory. So LADME is the mnemonic that you can use, where the pharmaceutical phase is the first L. So that's liberation, when the drug is released from the package. After that, everything else is the pharmacokinetic phase, which is what the body does to the drug. So A for absorption, D for distribution, M for metabolism, and E for excretion. And it's fairly logical if you just think about it in that order. Okay, so absorption and distribution. The first definition I want to go through is bioavailability, and that's the percentage of the administered drug that actually reaches the systemic circulation. Now, if it's oral, it has to go through the gut, so usually not all of the drug makes it. On the other hand, if it's intravenous, well, then it's going directly into the systemic circulation, so the bioavailability is 100%. Next concept is therapeutic index. The main idea here is it's calculated by using the lethal concentration over what's an effective concentration. So the higher the therapeutic index, the safer the drug. If you have a closer look at this graph here, I'll just point out that the drug is most concentrated where the graph is at a peak. And before that, we have the absorption phase, and after that, the excretion phase. Moving on to distribution, the biggest concept is volume of distribution. Now think of this as the total amount of drug that is in the body over the concentration of the drug in the blood. This gives you an idea of how far the drug is distributing into your body components. You don't need to know it in too much detail, but know that it is affected by certain factors. For example, if a drug is highly lipophilic, right, so more of it can cross into tissues. Or if it binds to the plasma proteins more, then it will stay in the blood more. More ionized drugs are more hydrophilic and less able to penetrate lipid cell membranes. Metabolism and excretion. So there's 2 types of metabolism, phase 1 and 2. Phase 1 is catabolic, so it breaks it down. The way I remember it is it's a catastrophe, so it's breaking things down. Phase 2 is anabolic and usually results in inactive products. Excretion, so the key concept is half-life, which is what it sounds like. So the time taken for the plasma concentration to half. This depends on things like volume of distribution and clearance. The rate of elimination is therefore the rate of clearance multiplied by the concentration of drug in the plasma. There are two types of elimination. First order is what the majority of drugs do. The same proportion of drug is cleared per unit time. So half-life remains constant, and usually steady state takes 4 to 5 doses to achieve. Some drugs, however, are zero order. So no matter how much drug there is, the same amount will be cleared in a given time. So this makes it easily saturated. So the half-life varies depending on the plasma concentration. Next question. So which of these regarding the therapeutic index is false? Yep, so I think most people got that one. So remember, the higher the number, the safer the drug. Everything else is just a fact. Yeah, so binding to plasma proteins would decrease your volume of distribution. If you think about it, actually, I'll come back to that in a bit. Let's do this question first. Yep, perfect. So you just want to remember the formula, elimination equals clearance by the plasma drug concentration. Yep. So I had a question in regards to the volume of distribution. Would binding to plasma proteins increase or decrease it? So as you see from this question or from this diagram, if you're binding to plasma proteins, then you're staying here, right? And if you're staying in the blood, it's not being distributed. So therefore the volume of distribution is lower compared to one that can actually be distributed into the tissue. Yeah. Okay, so let's move on to drugs affecting the autonomic nervous system. First, let's talk about cholinergic drugs. So all presynaptic nerves use acetylcholine as neurotransmitters acting on nicotinic receptors. And you can see that here. So these ones. So any drug that affects the nicotinic receptors are not specific enough because they're going to affect all of them. The other parasympathetic receptor is the muscarinic one, and this may have different uses. In general, muscarinic agonists activate the receptor and have effects such as constricting pupils, stimulating gut motility, bladder emptying, decreasing heart rate. An antagonist, on the other hand, does the opposite. So it blocks the muscarinic effects and results in dilated pupils, constipation, tachycardia, and so on. So some key drugs to know are summarized here, and I'll run through them briefly. So atropine has the effects of a muscarinic antagonist. So it has the effects we just discussed: dry mouth, fast heart rate, blurred vision, and that would be a result of the dilated pupils, constipation. It can be used clinically, for example, to treat severe bradycardia, where you have a really slow heart rate by increasing the heart rate. Hyoscine is another muscarinic antagonist with particular use in motion sickness. Remember, activating the muscarinic receptors cause gut motility, so blocking them would relax the smooth muscle in your gut. Ipratropium is another muscarinic antagonist, which causes bronchodilation and reduces mucus secretion. So it's useful in things like COPD and asthma. Pyridostigmine is similar to neostigmine, and it inhibits acetylcholinesterase, which is the enzyme that breaks down acetylcholine. And when it inhibits acetylcholinesterase, it increases acetylcholine. So it's useful for conditions like myasthenia gravis, where there is impaired neurotransmission. You probably don't need to know all of these in detail yet, but this is just to give you examples. Moving on to talk about adrenergic receptors. This is the sympathetic nervous system, so your fight and flight system, where postsynaptic sympathetic nerves use noradrenaline to act on alpha or beta receptors. So very generally, alpha receptors cause constriction, such as GIT, smooth muscle contraction, and beta cause dilation, such as in the beta-2 receptors causing bronchodilation in the lungs. Alpha-2 receptors are a bit different. They're located on the presynaptic nerve terminal and involved in inhibition. So the effects reflect this. An alpha-1 agonist is useful as a nasal or ocular decongestant with its vasoconstrictive effects, or with a local anesthetic, since it will decrease the distribution of the drug and make it last longer. As an antagonist, alpha-1 can be used in prostate enlargement to relax the smooth muscle. Alpha-2 activation has an inhibitory effect. So an agonist decreases the release of noradrenaline, and an antagonist would increase the release of noradrenaline. For beta receptors, I'll give some examples too. So a beta-1 selective agonist, dobutamine, increases cardiac output, whereas atenolol, a beta-1 antagonist, decreases the heart rate, blood pressure, and contractility of the heart muscle. Salbutamol, a beta-2 agonist, causes bronchodilation and is the blue puffer that we use for asthma. This is a bit of extra information about some other drugs related to noradrenaline. A simplified version, carbidopa, inhibits an enzyme involved in the formation of noradrenaline, so it reduces the noradrenaline amount. Clozapine inhibits monoamine oxidase, which is an enzyme that breaks down noradrenaline, so more noradrenaline is available to be reused. Finally, cocaine, this inhibits the reuptake of noradrenaline, which increases the extraneuronal noradrenaline floating around. It does take some time to wrap your head around the similarities and opposite effects. So I'd suggest first learning the effects of the sympathetic and parasympathetic activation, and then from there working out what the clinical effect of a drug interacting with the receptor would be. So let's move on to a few questions. Skip too far ahead. Okay. Yeah. So yeah, the main use for beta-2 receptor agonists is for bronchial asthma, which we just talked about, for example, such as salbutamol. Next question. Yeah, nice job. So salivation, sweating, bradycardia, meiosis, these are all muscarinic signs, and the mnemonic to remember is sludge, as in the diagram on the right. For me, I just remember that things are coming out of the body like sludge, so saliva, tears, urine, vomit, so on. And atropine is useful in this case because it's a muscarinic antagonist. This is a kind of a buzzword, but whenever there's organophosphate poisoning, think atropine. The other ones aren't as relevant. Neostigmine inhibits acetylcholinesterase, which breaks down acetylcholine, so that would increase the amount of acetylcholine. Yep. Good job. And yep, just what it does. Okay, yep. So we have a beta antagonist, and beta antagonists cause bronchoconstriction. So in this case, because it's non-selective, it's affecting all the beta receptors. The only one that doesn't make sense is that it would be dilating. Yep. Okay. Oof, let's see, what's the time? Yep. Okay, next, pain pharm. So we'll start by talking about simple analgesics and NSAIDs. We'll open with a question. New generation NSAIDs are designed to inhibit Awesome. So let's talk about this now. Apparently not. Let's talk about it soon. I just got a question about whether atropine being an inverse agonist rather than an antagonist. Honestly, the inverse agonist is basically that it binds to, but it causes antagonistic effects. So more or less, you kind of just think of it as an antagonist, even though it technically is an inverse agonist, because it's just confusing. We were just taught it as, learn it as an antagonist. Alpha receptor drug names that we need to know. Not off the top of my head. Yeah. Oh. Yeah, so let's just, so D would work too, but I guess you wouldn't really give it for mild pain relief when, I guess, for the side effects, it's not worth it when you can also use something much simpler, cheaper, and over the counter. Another question, in the exam, will they tell us the class of drugs or only the drug names? Honestly, it depends on them. Usually, for drugs that they expect you to know, something like propranolol, because they all end in lol, then you're kind of expected to know that. So really, it just depends on how they feel like. But if it's a drug that definitely you haven't heard of before, that it's not on your core drug list, they'll very likely give you the class. Okay. Would we need to know the trade names? Most likely not. That would be mean. I mean, maybe paracetamol is Panadol. Anywhere that I can find a full list of drugs I need to know. I feel like our PSP might have a drug list, but it's also very likely somewhere on the MUMUS drive. I'm thinking off the top of my head. I do remember putting up a list. I'm not sure if it's still there. Amazing. Thanks, James. Okay. So NSAIDs are non-steroidal anti-inflammatory drugs. They act to inhibit cyclooxygenase, which is the enzyme involved in making prostaglandins. There are two types. COX-1 is our constitutive enzyme, so it exists in most cells and it regulates housekeeping functions, things like platelet aggregation, blood flow in kidneys, GI mucosal protection. If we inhibit COX-1, then we get the opposite effects, things like platelet dysfunction and increased bleeding and GI ulceration. COX-2, on the other hand, is induced in cells and has inflammatory effects. So when we inhibit COX-2, we're reducing those inflammatory effects, such as pain or swelling, through decreased inflammatory mediators. However, these also run the risk of increased cardiovascular events. If we inhibit both non-selectively, we also have to consider the adverse effects. This leads to decreased gastric mucosal protection and increased risk of peptic ulcer, as well as prolonged bleeding time. Another thing is increased asthma risk, since leukotrienes are produced and they are a bronchoconstrictor. Some NSAIDs to know: aspirin is pretty standard. It's a simple analgesic and non-selective. Its effects vary depending on the dose and is often used as an antithrombotic. Adverse effects included, as mentioned before, GI irritation, increased bleeding, and also salicylate poisoning if you have too much. Ibuprofen, similarly, is another simple analgesic. Diclofenac is also non-selective and typically used in rheumatoid arthritis or other chronic pain with inflammation. You want to be careful with NSAIDs in some particular cases, such as GI ulcers, as we've mentioned. It can also cause sodium retention, so raise blood pressure, cause heart failure, decrease renal function. It's contraindicated in severe liver impairment. It's also not recommended in the third trimester of pregnancy because it may cause the ductus arteriosus, so that fetal connection between the aorta and pulmonary artery, to prematurely close. And also there's hypersensitivity and asthma risk because of the leukotrienes bronchoconstrictive effect. There are also drugs that are more selective for the inflammation side, that is the COX-2 enzyme. Meloxicam, for example, is mildly COX-2 selective, so there's less GI toxicity. Drugs ending in CYP, such as celecoxib, are highly COX-2 selective. However, COX-2 inhibition is linked to cardiovascular issues, so caution is required there. Let's talk a bit more about aspirin. I mentioned it was dose dependent before, so at a low dose, it is more selective for COX-1. So that reduces things like platelet aggregation, so it's good to prevent cardiovascular disease. At high doses, however, it's non-selective, so it's used more for reducing pain, fever, inflammation. Aspirin overdose is also called salicylism. To treat, you want to reduce the acidic state, increase the ionization of the drug, reduce distribution, and increase elimination. In severe cases, you might have to use dialysis. Another thing to mention is the so-called triple whammy, which is when you have an NSAID, an ACE inhibitor, and diuretics at the same time, which in short is just not very good for your kidney. So something to watch out for. Quick question before we discuss paracetamol. Okay, so yeah, it was day well done. Okay, so the final thing we're mentioning is paracetamol, which is not an NSAID. Paracetamol has no anti-inflammatory properties, but it does reduce pain and fever through a mechanism of action that is mostly unclear, but supposedly central. It is better for the GI than NSAIDs like aspirin. Overdosing on paracetamol affects the liver. The metabolite NAPQI is highly reactive and toxic, and it's normally conjugated to glutathione and excreted. However, this is saturable, so the antidote is to administer the precursor, N-acetylcysteine. Okay, let's talk about steroids now. First question. So yeah, let's move on to talk about this. So steroidal anti-inflammatory drugs act like steroids, which are hormones that are synthesized within the adrenal glands. Now, if we look over to the right, they act on phospholipase, which is higher than the COX enzyme by NSAIDs, so no cough or leukotrienes as a side effect. Glucocorticoids have both anti-inflammatory and immunosuppressive properties. They're used in conditions where you have adrenal insufficiency, such as Addison's, and inflammatory conditions such as rheumatoid arthritis and allergic disease. A bit on the mechanism of action: glucocorticosteroids cross the cell membrane and bind to cytosolic receptors. This then causes the receptor ligand complex to translocate into the nucleus. binding to promoter sequences on inflammatory genes to increase anti-inflammatory proteins and decrease pro-inflammatory protein synthesis. Therefore, this decreases vasodilation, leukocyte activity, histamine release, cytokine production, overall decreasing inflammation. Now, there are lots of side effects of glucocorticoids, particularly associated with high doses in the long term. Cushing syndrome now is most commonly caused by glucocorticoids therapy, so it's important to wean patients off therapy. Some side effects include delayed wound healing, since this requires a certain amount of inflammation, increased susceptibility to infection, since we are suppressing inflammation, fat redistribution, so that often presents as a round face, a buffalo's hump, so fat between the shoulders. Osteoporosis is another side effect because we're suppressing the body's ability to absorb calcium. Diabetes, high blood glucose, as steroids make the liver less sensitive to insulin and reduces glucose absorption into cells. High blood pressure is another side effect because there might be mineralocorticoid activity, which causes sodium retention in the kidneys and increases the blood pressure. So if you've been taking it for a while, gradual reduction gives the adrenal glands time to regain function, and that time depends really on medical and individual factors. Some core drugs you need to know: prednisolone, which is given as oral prednisone and converted in the liver. Dexamethasone is similar and some 25 to 30 times stronger than cortisol. Fluticasone, unlike the other two, is an inhaled corticosteroid, so it acts mostly on the lungs, reducing the inflammatory response. It's used as a preventer in asthma, reducing secretion and swelling. Because it's localized, it has less systemic effects, but can still cause issues such as sore throat, infection, and hoarseness. Question. Yep, so the answer is C. This comes up a lot in exams and definitely is worth knowing. Next question. Prolactin is another hormone, and kind of mean because you haven't learned it. It's also, it won't come up. Yeah, so this one was probably a bit trickier, but as I talked about earlier, remember that fluticasone is inhaled. So it's only working in the lungs. So you're not having effects on the whole body. It does reduce inflammation, so you're more likely to get infections. Nausea and vomiting is pretty much a side effect of all drugs. So as long as it's there, like ignore it as an option. Yeah. Okay, local anesthetics. Let's quickly run through how action potentials work. So when you have a stimulus and it crosses the threshold, then we get depolarization as sodium ions flow in. The cell repolarizes as potassium flows out, which overshoots in hyperpolarization before going back to resting state. So local anesthetics affect this up phase of sodium permeability. And what they do is bind to the intracellular part of sodium channels and prevent that influx of sodium into the cytoplasm. The action here is use dependent, so it blocks sodium channels only when they're open or inactive. A number of factors affect the efficacy of local anesthetics. Firstly, lipid solubility is proportional to potency. That is, the more lipid soluble the local anesthetic is, the stronger it is. Next, ionization and pH. Now, this is really tricky. So basically, local anesthetic tend to be ionized, but the more ionized, the more water soluble the drug is. The drug needs to be non-ionized to cross the membrane, then ionized to bind to the receptor. So in inflammation, where it's actually more acidic, the drug is more ionized and less effective. We talked about use dependence in the last slide, but basically, because it blocks sodium channels in open and inactive states, higher frequency firing actually leads to more effective drug action. As all drugs, absorption factors, so the dosage, the site of injection, blood flow, these are pharmacokinetic factors. Basically, the less blood flow, the more vasoconstriction. So the longer the effect, since the local anesthetics are most effective if they stay local. My final point on this slide is to draw your attention to the right, the order of blockage of local anesthetics. So the thinnest fibers are targeted first, and those are C fibers, which are our pain fibers. So the order goes pain, cold, warmth, deep pressure, motor, and the order of recovery is the opposite. Again, some core drugs to know. Bupivacaine and lidocaine are both amides, binding to the inside of sodium channels, inhibiting influx of sodium and depolarization. Bupivacaine has a longer duration than lidocaine. Tetracaine is an ester. Esters are rapidly metabolized, more likely to cause toxicity, and generally have a slower onset of action. On the other hand, amides, like the first two I mentioned, are generally more preferred because they're safer and longer lasting. Question time. Yeah, so there's this rule that Richard mentioned, and he says it's not 100% reliable, but it's better than memorizing. So if you look before the cane part of the anesthetic name, if it has an I, then it's an amide. If not, so like tetracaine, then it's an ester. Again, I'm not sure how reliable it is, but it's worked so far for me. Next question. Is the vasoconstrictor given before the anesthetic or simultaneously? To be fair, I'm not sure, and I don't want to give an answer. I would just say that it is useful with it because it's keeping it in the area. You'd have to ask an anesthesiologist. Yeah. So remember, pain is blocked first as the thinnest fiber, and in recovery, it's the last to come back. Honestly, I think the main one to remember are pain is first and motor is last, and that would probably put you in good stead for multiple choice questions. Oh, our last pain, oh, not really, but opioids. First question. Awesome. So, opioids are opioid receptor agonists, and the majority of an opioid's effects are from mu receptors. Other receptors, delta and kappa, exist, but mu receptors are expressed in greater numbers and exist in the brain, spinal cord, and periphery. So mu opioid receptor activation is the most important in terms of analgesia. When these are activated, it inhibits the transmission of pain signals. For example, if you've ever heard of runner's high after exercise, well, these are endorphins, which are endogenously synthesized and activate the opioid receptors, which, in addition to other effects, stop pain from being sensed. Exogenous opioids are externally synthesized and mimic these endogenous effects. So how do opioids work? In simple, activation of mu receptors in the brain cause analgesia, mainly by activating descending pathways that inhibit the release of transmission in the spinal cord. And therefore, they're decreasing the secondary neurons that project to the brain to carry that sensory information about pain. In the spinal cord, activation of mu opioid receptors also decrease the activation of secondary neurons projecting to the brain. Overall, this means that less signals are being sent to the brain about pain, so that brings out the analgesic effects of opioids. There are a range of effects associated with opioids, some very much unwanted. Analgesia is, of course, part of the mechanism of action, but it can also cause euphoria or the opposite, dysphoria, as well as sedation. It can slow the GI tract and cause constipation, which we can actually leverage in some drugs. Nausea, vomiting is an adverse effect in a lot of drugs, but particularly opioids because it stimulates the chemoreceptor trigger zone. It can also cause the release of histamines and associated allergic symptoms such as itching, bronchoconstriction, and hypertension. It can also cause addiction and dependence. Excess can be life-threatening, so acute overdose is treated with naloxone. Okay, core drugs. Morphine is your classic opioid drug. It has a high mu affinity and adverse effects, as I mentioned earlier. It is used in moderate to severe pain. And fun fact, it was named after Morpheus, the Greek god of dreams. Fentanyl is much stronger than morphine, has a faster onset and shorter duration of action, and therefore is particularly good for breakthrough pain. Codeine, on the other hand, has a weak affinity for mu receptors, and a small amount is converted to morphine. At low doses, it can be used to treat cough and diarrhea, and at higher doses for pain. Loperamide is an opioid that is poorly absorbed in the GIT. Remember, one of the adverse effects of opioids is slowing gut motility and causing constipation, which is great if you have really bad diarrhea. Loperamide has no analgesic activity. Naloxone, which treats opioid overdose, is an opioid receptor antagonist, so it does the opposite of all our other opioid drugs. A bit more information, tramadol is another drug that is not an opiate per se, but still an opioid agonist, as well as a serotonin and noradrenaline reuptake inhibitor, which also has some effects in inhibiting pain transmission. Adverse effects are related to increased serotonin, particularly if used with other medicines that increase serotonin as well. Excess serotonin can cause serotonin syndrome with symptoms such as diarrhea, tachycardia, fever, agitation, tremor, coma, and so on. So you want to be careful when using those drugs. Question time. Yep, good to see everyone has great short-term memory. Perfect. Let's talk about DMARDs next. So we'll focus on rheumatoid arthritis and gout. Rheumatoid arthritis is chronic autoimmune inflammation, which results in too many white blood cells. Gout is too much uric acid and inflammation resulting from uric acid crystallized and deposited on joints. So DMARDs are great because they actually control disease activity. However, they take a period of time before they actually work. The main ones you need to know are bolded. So methotrexate, leflunomide, azathioprine basically interfere with DNA synthesis, and these upset the liver. Cyclosporin acts to decrease T cell activity and doesn't upset the liver. The main gout drugs are also summarized in this table. Allopurinol is a xanthine oxidase inhibitor. Xanthine oxidase, as you can see here, is part of the uric acid production pathway, and inhibiting decreases uric acid. Probenecide, on the other hand, blocks reabsorption in the kidney, so it increases excretion. Finally, colchicine is a drug that acts on tubulin, which ultimately inhibits migration of white cells into joints and helps with symptoms. I may be butchering these drug names, so I'm sorry about that. Next, NSAIDs and glucocorticoids. We've discussed how they work before, but they might also be used in the treatment of rheumatoid arthritis. NSAIDs are great because they're cheap, they're good at controlling symptoms, but they also have complications that we've discussed before too. Glucocorticoids also have an anti-inflammatory and immunosuppressive effect and can be directly injected into individual joints. However, they do not affect disease progression. So these can be used to bridge the gap between starting DMARDs and the onset of action, since DMARDs do take a while to work. Yep, so great job everyone. Next question. Yep, so with these questions, honestly, it's just memorization, but having an understanding of how they work and what condition they're treating makes it a lot easier to memorize. Okay, our final topic for today is cardiac pharm. Cardiac pharm, instead of looking at the drugs individually, I think it's more effective to look at them in context. So some of these drugs have more than one use, but for the sake of simplicity, I've put them under different conditions to discuss. So first up, heart failure. This occurs when the heart cannot meet the demands of the body. And there's two types, impaired filling and impaired contraction. Now, if the heart cannot meet the demands of the body, how do we fix it? We can either make it work harder by increasing heart contractility, or we can decrease the work that the heart has to do. So first, let's talk about working harder. Let's talk about positive inotropes. Digoxin is the main one here. What it does is inhibit the sodium-potassium pump, and it increases intracellular sodium by calcium exchange. This increases the contractility of the heart and cardiac output. It's a drug with other uses too, such as for arrhythmias, and also has a lot of interaction. Also want to be careful with diuretics since it alters electrolytes and can cause low potassium. The other drug to mention is dobutamine. If you remember from way earlier, it is a beta-adrenoceptor agonist, and it increases contractility. However, it has limited use since desensitization occurs. For the next drugs, you need a vague understanding of the Renin-angiotensin-aldosterone system. So basically, when your blood pressure decreases, your kidneys release renin. This renin turns angiotensinogen to angiotensin 1, which is then converted by angiotensin-converting enzyme, or ACE, to angiotensin 2. This leads to effects such as aldosterone secretion by the adrenal cortex being increased. In the kidney, sodium is reabsorbed and other effects, which all ultimately increase water retention and raises blood pressure. However, in heart failure, we want to reduce the work of the heart. So we want to stop the renin-angiotensin-aldosterone system. This can be done through ACE inhibitors. These all end in pril, such as perindopril, and act to block the enzyme that converts angiotensin 1 to 2. This also inhibits bradykinin breakdown, leading to dry cough as an adverse effect. Alternatively, we can block angiotensin 2 receptors, and these end in sartan. This does not affect bradykinin, so there's no dry cough as a side effect. Diuretics can also reduce workload by increasing water and sodium excretion from the kidney, which decreases the circulating blood volume. There are three types I'll run through. So loop diuretics work on the loop of Henle, such as furosemide. Thiazide diuretics act on the distal tubule, and both of these have hyperkalemia, hypovolemia, and hearing loss as an adverse effect. Potassium-sparing diuretics act further on the collecting tubules and ducts. Spironolactone is an aldosterone antagonist. Others, such as amiloride, block sodium channels. Next thing to talk about is angina. So angina is chest pain that is caused when there is reduced blood flow to the heart and hence reduced oxygen. So if you want to treat angina, you either want to, 1, increase oxygen supply to the heart, or 2, reduce oxygen consumption. So nitrates act to increase granulyl cyclase, which increases cyclic GMP, which all up causes dilation. So venous dilation reduces the preload, and arteriolar dilation reduces the afterload. Nitrates are inactive orally, so you want to give them transdermal or sublingual, so under the tongue, where it dissolves and is absorbed through the tissue into the blood that way. You can develop tolerance to nitrates, and that's overcome by adding a nitrate-free period. You do not want to use it with sildenafil or Viagra because it amplifies the effects and can lead to deadly hypertension. Beta blockers we touched on earlier. So remember, sympathetic is our fight or flight system. Beta blockers block this, decreasing the sympathetic drive to the heart, so it reduces cardiac output, heart rate, and total peripheral resistance. In angina, the heart rate is decreased, so the force of contraction is decreased, so the heart requires less oxygen, and coronary arteries have more perfusion during diastole. Some drugs to know are atenolol, which is more beta-1 specific, and propranolol works on both. If you haven't realized by now, beta blockers are some of the nicest drugs to memorize since they all end in olol. As a blanket statement, beta blockers are best avoided in asthma, diabetes, bradycardia, and used with caution in heart failure. Calcium antagonists. So as the name suggests, these block calcium voltage channels, decreasing cardiac contractility, conduction, and causing vasodilation. So it's useful in angina, hypertension, and also some arrhythmias. There are 2 types. Dihydropyridine, such as amlodipine, have stronger hypertensive properties. And though they reduce blood pressure and total peripheral resistance, they may cause a reflexive increase in heart rate. Non-dihydropyridine, such as verapamil, also reduce blood pressure and total peripheral resistance, but these don't cause that reflex tachycardia. A memory tip, so di means 2, and we have 2 arms, so it affects the periphery more, and that is so that it affects blood pressure more and is more useful in hypertension. First question. Yep, so loop diuretics, thiazide diuretics are usually associated with hypokalemia. Yep, good job, guys. So it ends in thiazide, another great drug to remember. So a thiazide diuretic, and these act on the distal convoluted tubules to inhibit the sodium chloride cotransport. So yeah, well done, guys. So digoxin is the only one here with effects on the force of contraction of the heart, and it does that by inhibiting the sodium-potassium ions and increasing sodium-potassium pump and increasing sodium and calcium as a result. Okay, let's talk about arrhythmias. So arrhythmia is the term for when the heart is not beating in a regular rhythm. The bottom left diagram shows the 4 classes of drugs affecting cardiac action potentials, and I think it's quite a good summary diagram, so we'll work through it. So class 1 drugs block the sodium channels. So it slows down the conduction of action potentials. And there are a few subclasses. Lignocaine is a type 1B. Honestly, there's really no need to know the subclasses, but what it does is bind to the inside of sodium voltage gated channels and prevent the influx of sodium. If this sounds familiar, it's because it's also one of the local anesthetics we talked about earlier. Class 2, for some reason, act on the other end. They're beta blockers, which we talked about, and they help with heart rate. So they're reducing the sympathetic innervation to the sinoatrial node and hence decreasing the overall action potential generation. Class 3 acts when potassium flows out to repolarize the cell. So instead, with drugs like amiodarone, we block that outflow. So we're increasing the duration of the action potential. Sotalol, as the name suggests, is a beta blocker, but it also has class 3 activity. Finally, class 4 drugs may be familiar. These are the calcium channel blockers. Non-dihydropyridines are the more relevant here since it blocks calcium entry and it's suppressing the generation of action potentials. Remember, di meaning 2 works in the periphery, non-di, so not 2, acts more on the heart. The other two to mention don't quite fall into those classes. So digoxin, I've mentioned under angina, but it can also block AV conduction and hence low ventricular rate. However, if you use too much, it can cause arrhythmia. So you really have to be careful with this one. Adenosine also inhibits AV node conduction. It does this by hyperpolarizing and blocking calcium. It's a drug of choice for supraventricular tachycardia, so that's a bit of a buzzword. Almost there, guys. Yep, so that was E. Finally, atherosclerosis. This is what happens when cholesterol plaques build up in the walls of arteries, obstructing blood flow. Hence, you want to reduce cholesterol levels. Hyperlipidemia is also the most prevalent risk factor, so addressing abnormal lipids is also important. Also, remember we have different types of lipoproteins with VLDLs, LDLs as the bad ones and HDLs as the good ones. Introductory question. I am impressed. Yeah, we'll talk about this in more detail in a moment. So statins, another drug I love because their name ends in statin. These are competitive enzyme inhibitors for HMG-CoA reductase, which is involved in the synthesis of cholesterol in the liver. Hence, it blocks cholesterol synthesis and reduces cholesterol in the liver. This is used in the primary prevention of cardiovascular disease for those at high risk and secondary prevention after a heart attack or stroke. Fibrates, on the other hand, act as an agonist at the PPAR receptor alpha, which controls the expression of gene productions mediating the metabolism of triglycerides and lipoprotein. Activating the receptor increases lipoprotein lipase, and so fibrates are really good at reducing triglycerides, though they're less good at reducing cholesterol. On top of inhibiting cholesterol synthesis, we can also inhibit absorption. So bile acid binding resins bind with bile acid to stop the recycling of bile from the GI to the liver. This decreases the absorption of exogenous cholesterol, but increases metabolism of endogenous cholesterol to bile salts, and overall reduces the intracellular cholesterol in hepatocytes. Next, we can also decrease intestinal absorption, and this inhibits cholesterol absorption across the intestinal wall. It's better than resins in that it's better tolerated and does not affect fat-soluble vitamins. These may be used as an add-on to statins. Some others to briefly mention. So nicotinic acid inhibits VLDL secretion from the liver, decreasing LDLs, triglycerides, and increasing HDL. Fish oils, there's evidence that shows omega-3 fatty acids lower LDLs and increase HDLs. And PCSK9 inhibitors are a novel antibody therapy. PCSK9 is basically an enzyme that binds to LDL receptors in the liver and facilitate degrading of these enzymes by lysosomes. So when inhibited by antibodies, less of these receptors are degraded and more recycled to the cell surface. So more LDL uptake occurs in the liver. Whew, okay, so some final few questions to run through. Yep, so remember, verapamil is a non-dihydropyridine calcium antagonist, which does not cause reflex tachycardia. Which of these are likely to be used in first line? So furosemide is a very good diuretic. It will reduce the workload of the heart. It's probably the most effective one out of all the ones I've talked about. So it's first line. You definitely, I wouldn't say definitely, you'd more likely avoid a beta blocker because that's reducing the how hard the heart is contracting and the heart rate, which you don't really want if a patient's heart is already failing. The other ones aren't as relevant. Same with verapamil, you don't necessarily want to decrease the heart contractility when their heart is already failing. This does really depend on individual patients. So in general, furosemide is the best answer here. Yep, so more buzzwords. A contraindication of nitrates is Viagra. Basically, don't use them together. Yeah, so high potassium levels is a side effect of drugs like ACE inhibitors, statins, as well as potassium-sparing diuretics. So on an ECG, this shows up as tented T waves, then a broad QRS that gradually gets flatter. So it is important to take care when prescribing these drugs together. Almost at the end. Yep, so normally ACE enzymes also break down bradykinin. If we inhibit it, then we have more bradykinin, leading to that dry cough as a side effect. Again, another buzzword. If you see dry cough and hypertension, it's very likely related to ACE inhibitors. Final question. I'm mildly disappointed in everyone who got that wrong, but yes, this is Alfie, our PS Papa mascot, sadly not mine, but nonetheless adorable. So yeah, thanks guys for coming. Congratulations on pretty much finishing year 1. You just have your exams left, so smash those. And yeah, well done guys. You'll do amazing.